Good afternoon. Thanks, Peter, and I'd like to thank the organizers for inviting me to talk today. As Peter said, my task today is to discuss the upfront, who should get what for the upfront treatment for mantle cell lymphoma. I don't think that there is any right answer to this, but I do think there are several potentially right answers, and I'm going to go through the data that's led us to several of those trials today. And then after that, I'm going to take a little bit deeper look at some of that to see really how we should be interpreting some of that data. Then I'll talk a little bit about what's happening today that may affect treatment in the future, and then just touch briefly also on what we should be thinking about past what we're doing today. So why does this, what makes treating mantle cell lymphoma challenging? Well, for one, there's no upfront standard care for mantle cell lymphoma. There are actually several effective therapeutic options, many of which have been shown to improve progression-free survival and response durations, and in selective patients have shown benefits when you intensify treatment, add maintenance therapy, and consolidate with autologous stem cell transplant. But none of these have really shown a survival benefit in mantle cell lymphoma, and it remains incurable despite any of these therapies. So in a lot of patients, you really do have to balance the acute and late-term toxicities of your treatment along with the outcomes that you're getting from the response from therapy. Mantle cell lymphoma is not that common of a lymphoma. It represents somewhere of about 5% of the non-Hodgkin's lymphoma. And this really makes it a harder disease to study. The majority of studies that we have are not randomized phase 3 trials, but they're just smaller phase 2 trials looking at data, and in even some cases, retrospective data. Mantle cell lymphoma is treated heterogeneously in most cases, so treatment decisions are based on different patient characteristics such as age and comorbidities, and in some cases even risk factors of disease. And lastly, we actually have several prognostic markers that in either smaller or larger studies have been shown to help predict how patients will do, including the Mantle Cell Prognostic Index, Ki67, P53 mutations, SOX11, and complex cytogenetics. But none of these have been validated to actually predict responses to different therapies, and so it's information that we don't really necessarily know what to do with. So I'm not going to talk about most of the prognosis, but I am going to just briefly mention the Mantle Cell International Prognostic Index, or the MIPI, because it'll come into play a little bit later when I talk about the results of some of these trials. So the MIPI is a prognostic index that came from 3 of the randomized German trials, and it looked at 455 patients and the outcomes in those patients. And they identified 4 risk factors that help predict survival. These 4 risk factors were age and performance status, which is indicative of the patient you're treating, and then LDH and leukocyte count, which can be suggestive of the biology or the aggressiveness of the disease. With the calculated MIPI, they found that patients that were in the low-risk category had a median overall survival that was not reached and was actually 60% at 5 years, whereas those patients in the high-risk category had an overall survival of only 29 months. Again, this will come back into play later in the talk. So before I talk about how do we treat these patients, one thing to ask is, well, do they all actually need to be treated? Historically, mantle cell is something that has been treated at diagnosis, but given that it isn't curable, is there potentially a group of patients that you could observe prior to treating them? And our colleagues at Weill Cornell actually asked this question, and what they did is they retrospectively looked at patients that they were following for mantle cell and came up with a cohort of 97 patients. 2/3 of those patients were treated within the first 3 months of their diagnosis, but 1/3 of those patients were actually followed without treatment. The median time to following was 12 months, but they followed them. The range was actually 4 months to 128 months, with 3 patients going longer than 5 years without requiring any treatment. And at the time the data was published, they actually had 5 patients who hadn't received any treatment. When they looked at factors that predicted the ability to be able to observe patients, they found that performance status and IPI correlated to the ability to observe these patients. They also found that observing them didn't harm them, and in fact, the median overall survival in the observation group was longer than that in the early treatment group. Now, when you looked at the survival, when you took those patients who were observed from the time they actually got treatment to the patients who were treated early, there was no difference, suggesting maybe that those were just patients who at baseline had better behaved disease and were going to do well. So what about treatment? Well, as you can see, there's a lot on this slide. So historically, people have treated mantle cell lymphoma more based on the patient's age and comorbidities. So patients who are younger are often treated with more aggressive regimens, intensified chemo, and often consolidated with autologous stem cell transplant. And while those elder patients that are elderly are treated with chemoimmunotherapy and then maintenance, sometimes with transplant if they're young elderly, and then also with different rituximab maintenance regimens. Given that there's no standard of care, of course, clinical trial is always appropriate frontline treatment. So I'm just going to go through several of these trials. First of all, what about just looking at standard chemotherapy? It works in large cell lymphoma, it works in follicular lymphoma, so what about in mantle cell lymphoma? Well, this is results from a couple different trials, a phase 2 trial of 40 patients looking at R-CHOP therapy, and then data from the German low-grade group looking at R-CHOP versus CHOP. And what it shows is that in these patients with mantle cell lymphoma, R-CHOP actually has pretty high response rates, 94 to 96%. But the progression-free survival for these patients is not that great. So average PFS in the first study was 16.6, and that was independent of the response that people got. So whether they achieved molecular remission or not, they still had the same outcome. And then the second study was looking at R-CHOP versus CHOP, and what they found is while rituximab did improve response rates, there was really no difference in progression-free survival or overall survival with the addition of rituximab to CHOP. So good responses with standard therapy, but not very long responses. So next, I'm going to go to bendamustine. So this is a regimen that is used probably most popularly in both the young and older patients. So this is, bendamustine has been used since the results of 2 large trials came out. The first was a trial that looked at actually all low-grade lymphomas, untreated patients, and it had 517 patients that were actually treated, 77 of which were mantle cell patients. And this looked at giving patients standard dose bendamustine rituximab versus R-CHOP therapy. And what it showed is that the response rates with BR and R-CHOP were similar, but BR gave in a better complete remission rate and a significantly improved progression-free survival. Additionally, when you looked at it in just the mantle cell cohort, while the progression-free survival wasn't as good, it was still significantly better than R-CHOP. They also found that it was actually much better tolerated. So the R-CHOP had a lot more hematologic toxicity, infectious toxicity, alopecia, and neuropathy, while the BR group had more hypersensitivity and rash reactions. A second trial was a non-inferiority trial that validated those results and showed, again, high response rates with both of these regimens, but improvement in complete responses with bendamustine, and showed that bendamustine was not inferior to R-CHOP in these patients. And as I said, bendamustine has really become a regimen that many people use in both the younger and older patients. So this was actually recently reported in the New England Journal of Medicine, and this is looking at R-CHOP versus R-CHOP minus the vincristine plus the Velcade. So Velcade bortezomib is an active agent in relapsed mantle cell lymphoma, and there was some phase 1 data that showed that when you added it to R-CHOP, that it had improved response rates, but there was a higher rate of neurotoxicity. So this trial took patients, elderly patients who were not candidates for transplant, and randomized them to standard R-CHOP, and then R-CHOP without vincristine, added the bortezomib on days 1, 3, 8, and 11. And what they found is that there was actually significant improvement in complete response rates and progression-free survival, 14.4 in the R-CHOP compared to the bortezomib, which had a 24.7% PFS. They showed that both in the independent review and the investigator-assessed PFS that there was a significant improvement. There was also improvement in duration of response. There was not any significant improvement in overall survival, which is kind of a theme with mantle cell lymphoma. So this led them to say that this should be considered over CHOP. The last regimen I want to touch on is just the RBAC regimen. So I just want to touch on this briefly. This is a real small study, but there was a lot of interest in bendamustine rituximab, given its high efficacy and prolonged progression-free survival. There's also a lot of interest in cytarabine, which has been shown to improve responses in the younger patients when they're treated with stem cell transplant. So this study really looked at combining bendamustine and rituximab and cytarabine to see if that could improve patients' results in patients who weren't going to transplant. So again, this was a small study. It only actually had 40 patients, and half of them were relapse refractory and half of them were upfront. But what it did show was that there was a 100% response rate and a 95% complete remission with a 2-year progression-free survival of 95%. And so this has had a lot of interest recently, and also some questions if you could use this and then go to transplant. So what about maintenance therapy? I said that in the elderly, most of the time they don't go to transplant, but is there a benefit to giving them maintenance therapy afterwards? So the largest trial that's looked at this is the European mantle cell trial, and this was actually a 2-part randomization trial. So the first, they took 455 patients who were not candidates for transplant, and their first randomization was actually to therapy with R-CHOP versus RFC. And then they took patients who were in a PR or CR and gave them a secondary randomization to either interferon alpha maintenance or rituximab maintenance, which was given until progression, so not for a standard time. The secondary randomization took 316 of those patients were randomized to the maintenance. And what they found is that rituximab maintenance significantly improved remission duration. However, when you looked at the group as a whole, the overall survival was not significant. But when you just pulled out the patients that were treated with R-CHOP followed by rituximab maintenance, the median duration of remission exceeded 6 years, and there was actually a significant improvement in overall survival, leading R-CHOP plus R-maintenance, but this is given until progression. So patients are always on therapy. And then this, just briefly I'll mention, was just a second trial that looked at a modified hyper-CVAD regimen, so just gave the hyper-CVAD without methotrexate or cytarabine. This was an intergroup trial that was enrolled at multiple centers, and they showed here that they could also prolong progression-free survival with using a rituximab maintenance regimen. Now we'll get to a little bit even more aggressive therapy. So this is the data out of MD Anderson, which was actually mentioned in the last talk, looking at hyper-CVAD and untreated mantle cell lymphoma. So they actually took patients and enrolled, the patient enrollment on this trial was age 41 to actually age 81, and they treated them with 6 to 8 cycles of hyper-CVAD, alternating with rituximab and methotrexate and cytarabine. Patients who were in a complete response after 2 cycles got 6 cycles, the rest of the patients got 8. So again, while they found a very high response rate in this trial, 97% with an 87% CR, and then 3-year overall survival of 82 and progression-free survival of 64. This regimen was very toxic. 29% of patients were unable to finish. Over 90% had grade 4 hematologic toxicity. 5 patients actually died of acute toxicity, and an additional 4 from AML or MDS. When they looked at the failure-free survival according to age, they actually saw that it was inferior in those patients who were older than 65. This was actually validated in a multi-center SWOG study where they enrolled 49 patients with mantle cell lymphoma less than 70 years of age and treated them per the same regimen. Only 22 of these patients were able to complete therapy. Again, very high overall response rates, 2 and 5 year PFS and overall survival, but very toxic. 87% of patients had grade 4 toxicity. There was 1 death and 2 cases of MDS. A third hyper-CVAD study was done by the Italian group, and it showed very similar things. Those patients were less than 70 years old, same hematologic toxicity, death on trial, and MDS, AML. Despite the high response rates, these are toxic regimens, and in patients who are older than 65, they really aren't ideal therapies. So then this is a European mantle cell trial, which was the first trial that looked at a randomization to stem cell transplant in these patients. So they took younger patients and gave them a CHOP-like induction. And then patients who were in PR or CR went on to either interferon maintenance or went on to collect stem cells and go to autologous stem cell transplant. And in this study, they did show significant benefit to progression-free survival to the transplant, but again, no significant benefit in overall survival. This is really the first of several different transplant studies that have shown benefit to progression-free survival, but not overall survival. I'll just quickly mention, so there was the CLGB trial, 59909, which looked at giving patients a modified CHOP with rituximab and methotrexate. They got that for 2 to 3 cycles and then went on to mobilization with etoposide, cytarabine, and rituximab, and then transplant. This study enrolled patients less than 70. The overall response rate was 88%, 2 and 5 year PFS, 75 and 56%, and overall survival 87 and 64%. While there was, again, this prolongs the median progression-free survival, but no improvement in overall survival. There was a second study that they actually took this backbone and then added bortezomib, and they did a randomization between bortezomib maintenance or bortezomib consolidation. And what they found is that if you looked at it compared to the 59909, there was an improvement in the progression-free survival, although when you look at the bortezomib toxicity, there was actually about somewhere between a third and a fourth of patients who were withdrawn for toxicity, which included cytopenias and neuropathy. Still in this study, there were 2 treatment-related mortalities, so not benign therapy. This is the Nordic data. So the Nordic trials, actually, they had 2 studies, a mantle cell 1 and mantle cell 2. The mantle cell 1 actually looked at giving maxi-CHOP and rituximab and then going on to stem cell transplant. And the Nordic 2 trial looked at alternating CHOP with rituximab and Ara-C. So what they showed in this is, so in the mantle cell 2 trial, they had an overall response rate of 96%, again, 6-year PFS 66%, and 6-year overall survival 70%. What they showed is this was significantly improved from their trial that looked at just their mantle cell 1 that had treated patients with CHOP, and that this was a first study that showed that there really looks like there's a benefit to giving people cytarabine prior to transplant in both in progression-free survival. In the early study, there was actually a plateau of the curve, and there were no late relapses after 5 years. But then when they published their data later on, they showed a median overall survival was greater than 10 years, but they did have some late relapses. In this study, again, there were 8 deaths, which was about a 5% treatment-related mortality, in 1 case of MDS. So again, not benign. This is the European mantle cell younger protocol design, which was just further confirmation of the benefit of cytarabine prior to transplant. So this study looked at 6 of R-CHOP versus R-CHOP alternating with R-DHAP, and then both groups of patients went on to mobilization and transplant. This showed that there was not a significant difference in the overall response rates, either prior to auto or after auto, but a difference in the complete response rates, with higher complete response rates in those patients that received the cytarabine regimens, and a significantly improvement in time to treatment failure when you looked at those patients that alternated therapy versus just got R-CHOP. And then the French GILA study was a similar study that looked at CHOP and DHAP, and again showed similar progression-free survival as to the prior several transplant studies. And then lastly, I just want to touch base on this trial that was just presented at ASH. This was the Lima trial, and this was a first-line trial that looked at patients 65 and under who were given 4 cycles of R-DHAP and then taken to transplant, and then they were actually randomized to no rituximab versus rituximab maintenance. And probably no surprise, what this trial showed is that at a median follow-up of 30 months, the 3-year progression-free survival was 83% for those with getting the maintenance rituximab versus 73% with those with the observation. So you add on even more therapy and you can get these patients to prolong their response times, but still there was no difference in overall survival, although this was early. So when we really look at this data, what are some other things that we've learned? So in both the Nordic trial and the CLGB trial, they evaluated patients according with their survival according to MIPI. And what they found is that in the Nordic trial at 10 years, 70% of the patients with low MIPI were still alive, while only 23% of patients with high MIPI were still alive. And the CLGB showed similar results at 6 years. So the question really is, are we making those patients with low MIPIs, are we improving their outcomes by giving them more therapy and intensifying treatment, or are we actually over-treating those patients? Are those patients going to do well no matter what they do, and do we really need to cut back on their therapy? This was also shown in a third trial that looked at transplant both as first consolidation and then after relapse, and same thing, MIPI was very predictive of outcomes. And then the second thing I want to touch on is the MRD data. So from the first 2 graphs are from the 5909 or the first CLGB trial. This was a small number of patients, but what they did is they looked at MRD both after induction and then after transplant. And they found that for those patients that were in MRD negative state prior to even getting their transplant, they had significant improvement in both their progression-free survival and overall survival. They looked at the same thing in their patients treated on the 50403, so the second trial with the bortezomib maintenance. And they showed again that progression-free survival was, MRD negativity was predictive of progression-free survival, with all the patients on that trial at 3.5 years out still being in remission if they were MRD negative before they even got the transplant. So Dr. Pott and her group have also shown the same thing. They first looked at a small number of patients treated by the European trials and the German low-grade study. And what they did is they looked at MRD actually after transplant and found that there was improvement in progression-free survival and overall survival for patients that were MRD negative after transplant. They then reported about 4 years later results of 255 patients treated in both the elderly and young European mantle cell trial, and showed that in both, this was evaluating MRD before actually going to transplant or before getting their rituximab maintenance. And they showed that in both of those groups, patients who were MRD negative before they got either consolidation or maintenance had significant improvement in progression-free survival and overall survival. And then this was just presented at ASH, and this is similar data that shows that they tested MRD at several time points, even before getting transplant, after transplant, and then continued to test it every 6 months, and showed that MRD continued to be predictive as time went on of both progression-free survival, and that it was independent of MIPI, what patients were treated with, whether they got the transplant or whether they got rituximab maintenance. They also showed that detection of MRD in the blood predicted a clinical relapse of 87% of the time. And then patients who were MRD negative still at 1 year post-transplant had a 3-year progression-free survival of 80%. And this is just a graph showing all the transplant trials and the aggressive, the hyper-CVAD trials I went through. Again, all of these showed really similar response rates, and none was really superior to any other in progression-free survival, no benefit to overall survival. So what are some of the things we've learned? So in the younger patients, intensive treatment does prolong progression-free survival. And in patients who get transplants, cytarabine is an important component of that. But what we don't know is really how is that the transplant benefit is unclear. Are we is it just good biology and those patients are going to do well whether we don't transplant them, whether we give them rituximab maintenance, whether we give them autologous stem cell transplant, whether you transplant them and give them rituximab afterwards, or are we really making it better by transplanting them? Also, in those patients who do poorly, are we making their outcomes better with these maintenance therapies and transplant? Or are they going to do poorly anyway, and are they really the patients that we need to be looking at novel therapies for? In the elderly patients, and in some younger patients too, observation is reasonable in select cases, and probably those patients are going to do well regardless. There are several effective chemoimmunotherapies. Hyper-CVAD is not one that should be given because of the toxicity and inferior outcomes. And our maintenance has a role in R-CHOP, potentially other regimens, but they haven't really been looked at with BR, the bortezomib CHOP. So this is just a slide that looks at kind of my approach or our institution's approach to newly diagnosed treatment. So in younger patients, so all patients, if we have a clinical trial and they're eligible, will go on clinical trial because there isn't a right answer for these. In the younger patients, we do observation. In selected cases, we actually give the Damon regimen, so the rituximab augmented CHOP methotrexate with EAR and then stem cell transplant. But I've listed other possibilities, and then autologous stem cell transplant. I don't, and none of us at OSU have used rituximab maintenance, but I do know that some centers are starting to look at that or do that after transplant. And then for those patients who are not eligible transplant for either because of age or comorbidities, again, we put them on a clinical trial if we have one. BR is what we use, most of us use, and we do not give maintenance rituximab with the bendamustine. So what's going on now? So there are a few big studies going on right now that may affect therapy as we move forward. There's a 4-arm phase 2 study that's an intergroup trial led by ECOG that's looking at bendamustine rituximab versus bendamustine rituximab plus Velcade, and then patients undergo a second randomization to maintenance therapy with rituximab versus rituximab and lenalidomide. A trial that I think is probably going to have a lot of effect. This is a phase 3 randomized double-blind placebo-controlled trial that's evaluating bendamustine rituximab plus rituximab maintenance versus bendamustine rituximab plus rituximab and ibrutinib. These are non-transplant candidates, but I think the results of this will probably be used in both younger and older patients. And then the Europeans are doing the Triangle study, which is a trial that looks at R-CHOP, DHAP, followed by autologous stem cell transplant, versus R-CHOP, R-DHAP, followed by autologous stem cell transplant and ibrutinib maintenance versus R-CHOP, R-DHAP without transplant, and they get ibrutinib through their R-CHOP, DHAP, and then continue maintenance for 2 years. And lastly, that's where we're at now. Where should we be going? Well, there's a lot of new novel therapeutics in mantle cell lymphoma that I think need to be incorporated into frontline therapy, especially in those patients with badly behaved disease, and may be able to use some of those prognostic markers to help predict outcomes with these therapies. I think that we need to use these prognostic markers to guide therapy decisions, and we need to be better informed on what some of them mean. Lastly, I think MRD-based approaches, we need to start looking at for those patients who are in MRD negative remission prior to maintenance therapy or transplant. Do they really need that aggressive approach, especially with the toxicity that that's associated with?